So, on behalf of Associated Patient Advocates, it is my privilege to honor you this evening. Thank you for spending your time with us. Just a brief word about how we came about. We came about because we discovered that even though everybody tries to do their best in healthcare, sometimes it doesn't work out for the best for the people supposed to be benefiting from it, which is to say the patients and their families. This became clear, especially after I stopped practicing and wound up running around seeing friends and former patients who had been friends and discussing life with relatives, all of whom had encountered various glitches in what we would call the healthcare system. So we formed a company. Some colleagues and I, including Susan, who is our warm and fuzzy person. Susan is a licensed clinical social worker and counselor with many years of experience, which she can share with you. We also brought in a good friend of mine who spent many years administering a nursing home and really knows the nuts and bolts about finances, as well as healthcare settings. In addition, we have two registered nurses, one of whom worked primarily in operating rooms, the other of whom did home health, as well as patient education as a certified diabetes educator. We have a certified biller and coder to help out with those little pesky insurance denials and financial bills. So we try to be available. There is no one person who can do it all. I know several of the people on this call are also patient advocates, and I welcome you all. The format for this will be that Susan will introduce herself briefly and then launch into her discussion. After the discussion, we will have open discussion and question and answer and talk about whatever it is people wish to talk about. We will be posting this on our website, which goes by the poetic name of www.associatedpatientadvocates.org. And typically within a week, we will have the video link on our blog page. For those of you who have not seen our past videos, you can also access them via YouTube on our YouTube channel. But the simplest and most direct way is via our website. For those of you who found this seminar somehow, this next webinar and series will be posted as well on the events page at our website. Previous discussions have included nursing home placement and how it is paid for, given by our administrator, an update on breast cancer, sessions on healthcare finance. We did 3. One was on international comparisons with the United States and other countries. One was on Medicare, and the other one was on managed care. We also were blessed with a presentation from the Second Opinion, which is an organization that gives free second opinions to cancer patients that are based in San Francisco. And I know Susan is familiar with the people there. So welcome aboard, and without further ado, Susan, take it away.
Okay, thanks, Harley. First of all, I want to say that it's a pleasure to be here with everyone, and my work is my passion, always has been. I want to start by showing you a book. Can everyone see the name on this? So it's called Excellent Care for Cancer Survivors. And you'll note it says a guide to fully meet their needs in medical offices and in the community. And the community is key, and we'll get into that. So just a little background on me. I grew up in New York on Long Island, and I went to undergraduate school in Bloomington, Illinois, and graduate school at the University of Michigan in Ann Arbor. And then I came to Boston and I trained in many, many different types of places with seniors, with children, and a great deal of my work was at the Joslin Clinic, which is world renowned for diabetes care, and at Harvard teaching hospitals. So that'll all be included in my talk, and that's where I've received a lot of my experience. So as far as schooling, schooling is very important, but your real experience comes when you're working. And I'll be telling you a few stories about that. So my topic tonight is cancer and anxiety as a result. And I will at some point be doing a series of talks. I'd like to do one on diabetes and disabilities and maybe pulmonary issues, just to name a few. We're going to cover tonight what's called comorbidities, premorbid personality types, and survivors or co-survivors, which co-survivors are the family, and we'll get into all that. Let's start with anxiety. Okay, so we all know a little bit about anxiety. Everyone has anxiety. Anxiety is a fact of life. It protects us from danger, actually. We are unable to control all of our thoughts. Treatment for anxiety, and I want to stress this, is a gradual process of redirecting attention toward the fear, exploring it in detail as it arises and actually befriends us. And we'll get into that later too. Freedom from anxiety entails becoming disillusioned with our fear. A cancer diagnosis is often referred to as post-traumatic stress disorder. Many people don't know that. They say, oh, someone has cancer. They don't understand that it's a traumatic diagnosis. And when I refer to anything, and I will be more specific, traumatic refers to the patient and the patient's family. And to put it a different way, if you think about it, so the patient has a tremendous amount to deal with. The patient has to deal with all the treatments, and we'll get into all of that, and their feelings and worrying about how their families feel. So many people I work with spend so much time saying, you know, I don't want to talk about this, or I don't want to have to do this. It'll upset my mom, my dad, my husband, my children, that kind of thing. So that's the patient. Now, if you're the family member, which we're going to refer to as a co-survivor, you worry about your loved one going through everything they're going through. And then what about your feelings? Your feelings are just as important as the actual we call it designated patient's feelings. So all of that has to be considered. And everything I put my stamp of approval on has to do with the entire family. To the point, just to give you a little bit of a laugh, is that sometimes I'll have a family that I see and the whole family doesn't speak one word of English. And I have an interpreter in the room, and I, periodically I'll ask the interpreter, so the family talks and then I talk and the interpreter talks. And a lot of times I'll ask the interpreter, I don't understand what that could sound like, a lot of commotion. I don't really understand that. And the interpreter says, trust me, Susan, you don't want to know what they just said. So in their own language, I said, okay, that's okay. I get it. They're not too happy with this particular talk. Every patient and family member has what's called a premorbid, it's spelled PRE-MORBID, personality type. And this means that every person, before they were ever diagnosed with cancer, diabetes, pulmonary disease, anything in their life, having a baby, anything in their life, they were a certain kind of person. Some people are very positive. Some people are more histrionic, and some people are kind of gloomy, and they've had a lot of experiences in their life that feed that, and it's very understandable. But after careful psychosocial assessment, which I do on every single person I see, I can determine their premorbid personality type. And that's how I know right from the get-go how a person is going to respond to what we're doing. So in other words, example, if a person is a very positive person to start, and then they become diagnosed with cancer, say, for example, they will eventually resume the personality that they had prior to ever being diagnosed. That's really key. So people will say at some point, well, how did you know I was going to do so well? I was doing great. I was crazily unhappy, and I was so sad, and I was so frustrated, and I don't think I was even responding to the treatment at times, and I don't know, et cetera, et cetera. And I say, I know, because I did a psychosocial assessment on you and I did an evaluation. So I know your pre-morbid personality type. And that goes for adults, it goes for teenagers, it goes for young adults, and it goes for children. I'll get into that later. So remember that. So if a person has always been positive, he or she will react as positively as possible, note the as possible, after going through and during all that must be done. Some of the steps of grieving that everyone goes through, but I don't like a certain order, because an order assumes everyone's the same and everyone is not the same, everyone's different. So some of the steps are disbelief, shock, tears. Why me? How could this happen to me? I don't understand. I haven't had enough issues in my family and in my life, and now I'm going to deal with this. How did this happen? And then how am I going to deal with all this? This seems like much more than I can possibly deal with. And I want to stress that it is a slow process of integrating all of this into your life. The feelings do not go away. They do not go away. It is a trauma. It becomes an integral part of a person, whether it's the family or it's the patient. Very, very key point, an integral part of a person. We'll get into that more later. Significant others may proclaim, wow, we should celebrate. You are done with treatment. And that's good. And I'm not saying boo about celebration. I love to celebrate. I'll be the first one to come to a celebration. However, no one is done. There's follow-up. There's a lot of worry. There's an awful lot of emotions involved. There's a lot more to come. And so, yes, celebrate, but celebrate knowing that there's a lot more to come. We're not at the end of any of this for the family or for the patient. Overall, coping mechanisms to incorporate in your life involve and include healthy eating, exercise as possible. Note that I'm not going to say go to chemotherapy and go for a workout. That would be stupidity. But do what you can do, because moving is very, very important for your good mental health and your physical health. Mindfulness, meditation, and it's very important to try to get on some kind of a routine. A routine is very important because it helps you sort of focus. And life is so complicated. If you have a focus, you kind of know I'm going to get up around this time, and I'm not really hungry, but I'm going to kind of force myself. I know I have to have a little something, so I'll have a little toast or I'll have a smoothie, and then I'll do thus. And so it kind of puts you on a routine, on a schedule. And that's very, very important. The other thing that helps a lot is journaling. And journaling is not that you need to write something that's going to be published in every magazine. Actually, it's very private, but it's kind of getting your feelings out. And just to share a story, when I lecture at John Muir, I did the I Can Cope series for years and years before they discontinued it. And I would tell people, take 45 minutes to an hour or whatever time you want every morning or whatever time of the day, but a consistent time. Be as angry as you want. You want to throw something across the room because you're so angry? Do so, but don't throw your favorite painting across the room and shatter it into a million pieces because you're going to be sorry. But allow yourself the feeling. Then with the feeling and with getting out your emotions, take a shower or do whatever you're going to do, and then go about your routine. So keep in mind throughout my talk, the word routine. It's very important. The next part I want to cover is coping with fear of recurrence after cancer treatment. Fear management. Talk with a medical team conference and conference with the doctor. Know whom to ask what issue. Know with whom to discuss which issue. Very, very important. And then it's important to develop cognitive approaches. One thing I do a lot of is called cognitive behavioral therapy. And an example of that, I'm going to give you an example. There are a million examples, but an example would be you take a situation. And let's say the situation is, I am told I need to have radiation. That's your situation, just say, hypothetically. Then you take your emotions about your situation. They might be fear, frustration, anger, tears, sadness. Okay. Then you take your thoughts. I don't really want to do this treatment. Why should I have to do more treatment? I've had enough treatment. How will it affect me? It's so inconvenient. Those are a few of the feelings. And then that cycles around to your behavior. And your behavior, the best scenario here would be, okay, behavior will be, I will research this thoroughly, and then I will make a decision. I don't have a decision yet. That will be step one. I want you to keep in mind that prior to my direct cancer work at Epic Care in Dublin, Castro Valley, and Emeryville, I worked at Travis Air Force Base. And at Travis Air Force Base, this was very, very important because we worked with a lot of people that needed all kinds of treatments. They didn't want to have the treatments such as amputations and all kinds of things, losing limbs, and they came in with all kinds of horrendous problems. And we had to work very, very carefully on that to figure out what is the best plan and how are we going to get the person to follow through with the plan. And that's key, very, very key. The person has to buy into the plan. I could do cognitive behavioral therapy, I did, with families and patients for maybe months and months and months, so they came up with a plan. Okay. And the other part of cognitive behavioral therapy is knowing your patient and family and knowing where they're coming from. So you know how to kind of spin it to get the behavior that's best for them. And one example of that was a person who didn't want to have surgery, and the doctor at Travis sent them to me. Find out why she doesn't want to have surgery. I can't get it out of her. So we talked and talked and talked, and finally she told me in hysteria that she was attacked in a elevator as a young girl. This woman at this point was maybe about 65, so she was still young, but when she was young, like around in her 20s, and she's afraid of knives, and she's not going to let any doctor use a knife to work with her. And the surgeon says, I have to use a knife, you know, I have to do surgery. And the doctor was kind of upset with me because he said, well, I don't understand why the patients tell you and they don't tell me. I said, I don't know, but you sent them to me, so what difference does it make? They told someone. And then once we worked that through and the doctor understood, and the surgeon approached her in such a way that it was understood that this is going to be very difficult and this is how we're going to do it, etc. The more she understood, she was much better about it. But the point is that she had to decide, and the doctor had to understand why she was feeling the way she was. That's very, very important. Another thing that really helps with fear, to get back to that, is therapy, which is what I do. As I said before, staying focused, positive self-talk, very, very, very important. And I want to stress again right here that I feel strongly about dealing with the entire family. Everyone has something to offer. Okay, so I'm going to give you an example now of two twins. They were 6.5 years old. They came into Epic to see me. The mother wanted to see how they were coping. And the two twins, first of all, one told me that they wanted ice cream and one wanted something else. So I got them treats so they would talk to me. Anyway, they ended up telling me, one says, my mother's doing great. She does everything the doctor says. She follows through with all the treatment. Everything's wonderful. The other twin, it was a boy-girl twin. The other twin says, you're crazy. Mom does nothing. She doesn't do anything the doctor says. So, you know, we had a little problem there. So I got to see them on an ongoing basis, and we finally, you know, worked out the issues. But the point is, somebody might say, what the heck are you working with 6.5-year-olds for, right? But why not? Why wouldn't I work with them? They're members of the family. So that's very important. The other thing I want to say is I want to talk a little bit about chemo brain and this has to do with how important it is to have an advocate going through this. So chemo, we call it chemo brain, and everyone thinks it's a funny joke. It really is not. In chemotherapy, there are actual cognitive changes that occur, and it results in confusion, a lot of memory loss, etc. And it's extremely frustrating when an unusually accomplished patient feels that they can handle everything. Maybe they're a lawyer, maybe they're a wonderful teacher, maybe they're a spokesperson, maybe they're a mom, whatever they are, and they always handle everything. And all of a sudden, they can't think straight. It's a terrible thing. And the story I like to tell about that is one of my dear patients went to the supermarket and bought a chicken. And she also went to the bank and took out a few $100s. So she came home and she defrosted the chicken, and she's looking everywhere for the $200, and weeks go by, month goes by. She can't find the $200, and her husband finally says, forget about the $200. Where could it have gone? It couldn't have walked itself out of the house. It must be somewhere. 1.5 months later, she defrosts the chicken, and guess what? Voila, $200 in the chicken. And I told her, we laughed so hard, the two of us, I told her that was a really safe bank. Put all your money on chicken. Who's going to ever go in your freezer, defrost everything in the freezer to get money? So I thought that was pretty clever. Okay, past and present advocacy. So advocacy is done in hospitals, in schools, in nursing homes, in office visits, in people's own homes, on the phone, in Zoom sessions, etc. And the reason advocacy is so important is everyone needs an advocate. If you think about it, I know I do. We all need advocates. We all need someone who can listen for us and can be there for us and can be the person we can lean on. And that's why so much of this is so hard for the families, because the families feel, they lose energy because they're so stressed about it too. They have so much anxiety also. And I want to share with you something very, very important to me and dear to my heart. I worked for 8 years for Epic Care, and my job was to do all the psychosocial intervention with the patients. And I'm very proud of that because my boss, who was one of the 2 doctors that started the practice, Dr. John Gainey, said, we've never known anything about psychology here. We don't do any psychology. We do the medical. We have little nutrition, and we have nurses, and we have nurse practitioners, but we have no psychology. I said, no problem. That's right up my alley. So I would do an interview on all new patients, as many as I could get into a day. I was kind of tired at the end of the day because they had me booked like every 15 minutes off the whole day. But the point of the story is that I did assessments on everyone and tried to figure out who needs me most, what family members need me most. And then I saw everyone. We put everyone under the patient. So there was a doctor, then there was myself, then there was a nutritionist, and we did a whole comprehensive team approach. And then we would have meetings and discuss people. Many, many times, one of my beloved doctors there, Dr. Kankapati, who isn't there now, has since moved to Florida, used to call me out of my office. I was sitting in my office with a patient, and she would knock on the door very gingerly and say, Susan, and then to the patient, I'm so sorry, but I need her just for 3 minutes. And she'd bring me into an office, and she'd want me to meet the family or the patient because they were real scared about talking to someone. And she thought that maybe I could put them at ease and they could put a face with put a face on the person. And then I would go back to my session. Everyone understood because everyone there was in the same situation. So whether a person comes in with breast cancer, ovarian cancer, pancreatic cancer, brain cancer, et cetera, bladder cancer, et cetera, everyone has their own set of problems and everyone has their own set of challenges. And one thing that I feel was I wish I could still do, was a great source of advocacy, is we had a yearly gala that I created. And one year we went to Arlen Ness Motorcycles, had a big Christmas party. And one year we went to Concannon Winery, and we set up the Epic clinic as a beauty salon and had hair stylists and makeup and food and presents. And we did a lot of things like that. And one patient wrote a letter, many patients wrote letters to the head doctor, but what they all said was, quote, for just one night, I may cry out, I'm gonna try not to, for just one night, everyone in that room understood me. Everybody in the room. At Kankana, we had 750 participants. Then we went to the Roundhouse, so we had 550. And that night, people came out that hadn't been out for a year. People came out that were going through horrendous treatment, and we're all dressed up in Christmas attire, and we had Santa Claus, and we had Santa Claus come in on a Harley, you know, and all the kids singing. It was so joyous. I just wanted to share that. And also wanted to share that there's a lot of advocacy needed when I ran the leukemia group, which I did the pediatric leukemia group for years. That was a great joy. Sad in very many ways. It was very sad. We went through tremendous things together and became a family. But it was a group for all the children with leukemia and all the parents, and then all the siblings. And all the children and the siblings we sent into another room to have pizza and cookies to their heart's content. They could have as much as they wanted. And I kept all the parents, myself and a nurse practitioner at John Muir, and we would run the group. And it was great for the parents because they could really vent and we could really talk about all the issues. A little bit in a sum up, the challenges that I see, they're emotional challenges, social challenges, physical challenges, and spiritual existential challenges. Emotionally, and there are many more, I'm just being concise here, fear of a recurrence, worry, and the unknown. The social, relationships, marital stress, financial stress, pre-existing non-coverage on the insurance's part, lots of fights with insurance. We're very good at that too, by the way. Lifestyle changes. Physical, sleep disturbances, anxiety, depression, terrible fatigue, terrible nausea, et cetera. And spiritual existential challenges, reconsideration of priorities. And cancer can be very transformative. When someone's had cancer, life is never the same. And that's really important to remember. You're never the same after you go through this, whether you're the family member, whether you're the patient, you're not the same. You couldn't be the same. So I don't know anyone who doesn't need an advocate. And I'm going to end. I have many stories, but I'm going to tell you two. Okay. The first story took place in Boston. And I was working at a Harvard teaching facility in Boston. And I had a patient who had to have a below the knee amputation. She had gangrene from uncontrolled diabetes. And she was very depressed. And she had a husband and 2 little children. And it was maybe 4 o'clock in the afternoon, and she was supposed to have surgery the next morning. And I was the therapist on that unit, and I took my job very seriously. So I went to the nursing station and I asked who the surgeon was on this particular case. And they told me, the name didn't mean anything to me. And I said, how do you get a hold of this doctor? And they said, we could page him. We'll get a hold of him. So the doctor comes to the unit, and I said in my very respectful way, I'm always very respectful, would it make a difference in the prognosis of this young woman if the surgery was delayed by a day? He said, no, it would make no difference. I said, okay, I'm just wondering because she's severely depressed and I don't feel she will do well in surgery being that depressed. I think if you gave me a day to work with her, she'd be in better shape the next morning. Next thing I know, I hear on the loudspeaker of the whole hospital, will Susan Roberts return immediately to her department? So I went back to my department in my white coat. I thought, I was 24 years old. I was just doing my job. I walk in, there's the director of public relations, the surgeon, and my boss. And the surgeon speaks first. And he says, I want that young woman fired immediately. No one talks back to me. And then he proceeds to say, do you know, young woman, I am the head of surgery at Harvard. Hey, if I'd known he was a head of surgery, I might not have paged the man. That's why all the nurses were giggling at the nursing station. They could not believe what I was doing. I didn't know who he was. So my boss said, what's your side of the story? You're always very professional and respectful. So I explained, as I explained to you, my side of the story. So the surgeon on that point left. The head of PR said, not only should you never fire her, you give that young woman a raise. It's about time someone had the courage to speak up, to speak their piece with him. So I was like, yay. And then the other story I want to tell you about advocacy and why it's so important took place at Travis Air Force Base. And we were called the ALIKI team, and ALIKI stood for all in knowing the individual as a person, all in knowing the individual person. And we covered certain units of the hospital. So one of our units was the intensive care unit, and I was part of family medicine, and I was a psychological part of the team. We had a pharmacist and all the family medicine interns and residents and the doctors and everyone. So we were in the ICU one day, and I had a client from the Philippines, a man probably about 80 years old. So I came back to a room which they called the doc box. Everyone met there, and that's where we, talked about it, all the different patients when we had rounds. So the doctors were saying this particular man wants his, at some point when he passes, we want his remains taken back to the Philippines. And I'm listening, and I said to myself, I don't think that's what he said at all, but I didn't want to be impolite, so I didn't know. So I went back to the ICU, and I had a discussion with the patient. And he said in kind of broken English, the best you could, what are they all crazy over here at Travis? I don't want my remains going to the Philippines. I want to go to the Philippines. So I go back to the doc box and explain it to everybody. And they say, well, we are the ALIKI team, which means we're the greatest advocates, and we have to do everything we can to help them. That's our job. So I got on the phone with the Philippine Airlines, and they actually offered me a ticket to the Philippines. I said, that's okay, I can't go to the Philippines. But this patient and his daughter, who is a nurse, want to go to the Philippines. I explained the whole situation. And then we called the oxygen company and the wheelchair company and everybody. And we had, I think we needed a ventilator. We had everything situated and everything donated. We advocated like really hard for this person. So we're in the doc box, and all of a sudden I hear attention, and everybody stands at attention. And in comes the colonel, I think that's the head honcho of all of Travis. And I don't know, didn't faze me. I just was at my computer, and he says, does anyone here have the last name of Bucker? And I tried to slide under my computer, but I couldn't quite do it. And I said, that would be me. And he said to me, young lady, do you think really we can discharge? I heard a rumor in the intensive care unit that this team is trying to discharge a gentleman who's in the ICU, who's about to go on hospice to the Philippines. Nobody gets discharged from the intensive care unit to an airline to the Philippines. What are you doing? So I don't know. I think God kicked in. I don't know who kicked. I'm sure it was God. And it came out of my mouth. I wonder how you would feel, sir, if we discharged him on hospice. That's genius, he said. I don't care if you discharge him on hospice, and then hospice can discharge him and go to the Philippines, but no one can be discharged from my intensive care unit to the Philippines. Do you understand? I said, yes, sir, I understand. So we all got back to our meeting, and we called hospice, and hospice said, you're going to do what? I said, this is a little unusual, but we're going to discharge this gentleman to you, and he's going to be with you for 2 hours. I said, what? What do you mean 2 hours? I said, just bear with me. I have a plan. For 2 hours. And the head of family medicine said, she's correct, 2 hours. And then he and his daughter have a 6 o'clock flight to the Philippines. You're going to discharge them, and they're going to leave you and go to the Philippines. So all the doctors were betting money. They were all betting because no one believed he could get to the Philippines. After all, he was very, very ill. But we got on the plane, and I asked the airline, what happens if this gentleman does not make it to the Philippines? And they said, don't you worry one bit. We had this happen. We can deal with it. Don't you worry. You're doing the right thing. And do you know, try not to cry again, do you know that this man lived for 3 months in the Philippines surrounded by his family? And I thought that was, I didn't know Harley then. Now I know Harley, Dr. Harley Schultz, and I love the man. He knows that. He's great. But you know what? I didn't even know that this was all going to come about. So I figure I'm a natural advocate. This is just what I do. I've advocated when I was 24 and when I was a young girl, and I used to work with people with emotional challenges, which I'm a great fan of working with that. And I sincerely feel that everyone needs an advocate. Every family member, everyone needs someone to stand by them. And we are the people who can help, because I don't know, every one of my colleagues is very dedicated. And when Dr. Schultz asked me, would I be the therapist, would I do the psychosocial with him, I was so honored, and I'm enjoying it every day. So with that, I could tell you stories all day, but I don't want to keep you all night. I want to have time for questions, but I want to say, don't be hesitant about getting help. Don't feel you're alone. Remember what they said at the gala about everyone understanding. We're here and we understand. And everybody, whether you're the co-survivor or the family member, which is the co-survivor, whether you're the survivor, meaning you're getting through your treatment and you've gotten through your treatment, whatever kind of personality it is that you have, let us help you. But I think the story in the Philippines is a great example of how we have to listen. We have to understand, what does this man really want, and can we help him? And are we crazy? Yeah, sometimes as advocates and as therapists in the health profession, we can be a little crazy, actually. We have to think out of the box. We can't, everyone knows that. Everyone that I know and love and work with knows that the doctors aren't always right, the therapists aren't always right. I'm clearly not always right, and they're not always right. But as a team and all working together, we can come up with the right answer. And that's what we're here for. And it's an honor to be here tonight. Thank you so much.